It's time for another podcast by George. Straight talk, straight from the heartland, that'll have you saying, "By George, I think he's got it." Now, here's George.
Hello, hi, how are you? Welcome on in to another podcast by George. Well, I promoted this podcast a little bit on the website because I knew I would get some questions, and I did, from folks for our good friend, Dr. Andrew Nish, regarding the COVID situation. That's top of mind. It's all over the media everywhere. Looks like we're getting another wave of this, and we'll talk about that. And then also, there's an Alzheimer's drug that's getting a lot of news, and of course, it's a huge issue, particularly with the older demographic in America, and we want to talk about that in particular. But before we introduce the doc, I wanted to talk about this article that I saw just this morning, actually, in USA Today. Now, this was written by Karen Weintraub of the USA Today. She says a doubling of COVID-19 cases in the past 2 weeks suggests the United States has entered a fourth wave of the pandemic. The fourth wave. The example of the United Kingdom suggests the infection rate could get high, with hospitalizations and deaths staying relatively low in comparison to what we've been used to. Instead of the virus raging through entire communities, it is likely to target the unvaccinated, including children, and if rates are high enough, the most vulnerable of the vaccinated. The people that have been vaccinated could also be at extreme risk here. The elderly and the immunocompromised is the word that they say there. I wanted to read this particular statistic as I thought this was very interesting. More than 99% of those hospitalized with COVID-19 are unvaccinated. Now, that's according to Louis Ostrowski, the chief of infectious diseases at UT Health and an infectious disease specialist at Memorial Hermann Texas Medical Center down in Houston. So he's talking about his facility. Now, they're all unvaccinated. He said virtually all his patients are unvaccinated, and all of them, after they get it, regret the fact that they did not get the shot. So that's, oh my God, that's a view from Houston. But let's turn to the heartland here and Dr. Andrew Nish. Doc, welcome back to a podcast by George.
Thanks, George. Good to be here.
You know, and I've talked before on the podcast about how it kind of seems like everything good and bad comes in from the coast. It comes in from overseas, everything from the Beatles to bell-bottom pants to, everything art and music related. We all seem to get it a little bit later, but it eventually ends up in the Midwest. Is this fourth wave making its way into the heartland?
Yeah, I mean, it is. We don't get the publicity of the LAs and the Houstons and things, but it is making it into the heartland. And, let me just give you some local examples. So I get a status report every week from the hospital about, COVID transmission rates and hospitalization rates. And last week we had 6 people in the hospital. Now we're up to 9 as of this week. So if you look at transmission rates, and that's the number of new cases per 100,000 people. Back on June 28th, it was 14.9. So we consider low transmission anything less than 10 per 100,000, moderate transmission between 11 and 50, high transmission over 50. And let's jump fast forward to today, and our transmission rate is now 33.4 per 100,000. So we've more than doubled our transmission rate in 3 weeks. So that means that the number of new cases per 100,000 people is over 2 times what it was 3 weeks ago.
Wow.
Your point with the national headlines that more people are getting COVID, and they are the unvaccinated. So if we look at our rate of hospitalizations, over 95% of people hospitalized have not had the vaccine. Mercy's number is 97%. So the vast majority of people in the hospital are the unvaccinated.
Yeah. And for the vaccinated, with this Delta variant, and we talked about this earlier, I don't know, is it a huge issue yet? Are vaccinated people, is that breakthrough thing that they talk about, is that coming through? Is it striking people in the elderly demographic?
Have not seen that yet.
Okay.
We've not seen Paul Offit, who's one of the leading vaccinologists in the world, talked about that the other day and said, we're just not seeing vaccinated people landing in the hospital with this Delta variant. So what we are seeing is that the current vaccines, 2 doses of the Pfizer, 2 doses of the Moderna, single dose of the J&J, are still seem to be highly protective against the Delta variant. One dose, not so much. So we've got to have 2 doses of the 2-dose vaccines.
And a significant portion, not the majority certainly, but people that got the 2-dose, what's supposed to be a 2-dose vaccine, there's still a lot of people that only got 1 dose of that 2-dose regimen.
Yeah, I don't know that statistic. I don't know, what percent of people, I haven't kept up on that, got just the single dose. But we know that it seems that the single dose is not protective very well against the Delta variant.
Yeah, I read the news and I see these headlines. I always end up with a lot of questions that they don't seem to cover. One that I've always had, okay, they're talking about people that are sick enough now to end up in the hospital. Well, okay, if you're not that sick, but you still get COVID, and you've been vaccinated, you have mild symptoms. Can those mild symptoms be mild long haul symptoms? You know what I mean? I mean, can you get sick with this and just have a mild case of it, but have it for a long time?
In the vaccinated population,
Yeah.
I don't think we know the answer to that question because we just frankly haven't seen enough vaccinated people getting COVID. So I don't know if we know the answer to that question.
And I thought of that immediately when I saw that news, and Fox in particular making a big deal about it because it's these 3 Democratic legislators out of the state of Texas. Now it's 5. They all flew to Washington, D.C. because of a political situation down there. They're all on a plane together. None of them wore masks. And 5 of the delegation now who are fully vaccinated have COVID. They've tested positive, but some of them weren't even aware. I mean, that's how little symptom they have. I mean, they don't even know that they've got it. If they weren't tested, they wouldn't even know it. But so I wonder if they continue to carry it. Do we know whether or not they can shed it or can?
So let's go back to the original approval of the vaccines.
Yeah.
Okay, the vaccines were approved not to eliminate COVID, but to prevent serious infection, hospitalization, and death. So we know that the vaccine, people can still get mild cases of COVID with the vaccine. They just don't end up in the hospital, the ICU, or dead.
Right.
And so we have to go back to the original premise of the vaccine, and that's to prevent severe disease, not to prevent all disease. So when we talk about 90%, 95% efficacy, we have to remember what efficacy means. It means you're not in the hospital, you're not in the ICU, and you're not dying. You still may get a mild case of COVID, but that's what the vaccines are designed to do. Whether people are shedding the virus or not, early studies showed that viral shedding was significantly less with the vaccine. Is it 0? I'm not sure we know the answer to that, but we do know it's protective against severe disease. So your point on these Democratic legislatures, they don't have severe disease. They may be mildly symptomatic or asymptomatic. That's what the vaccine's designed to do.
Let me bring this up on screen and get your take on this here. The headline is, all children should wear masks in school this fall, even if vaccinated, according to a pediatrics group. The American Academy of Pediatrics just today recommended that all children over the age of 2 wear masks when returning to school this year, regardless of vaccination status. Now, this is really interesting. The AAP, which said it's important for children to return to in-person learning this year, they support that, recommends that school staff also wear masks. The AAP is calling the new guidance a layered approach. We need to prioritize getting children back into schools alongside their friends and their teachers, and we all play a role in making sure it happens safely, said Sonia O'Leary, chair of the AAP Council on School Health. Combining layers of protection that include vaccinations, masking, and clean hands hygiene will make in-person learning safe and possible for everyone. The AAP said universal masking is necessary because much of the student population is not vaccinated, and it's hard for schools to determine who is as new variants emerge that might spread more easily among children. So when you look at that, it kind of looks like they're being extra cautious, particularly with the potential for new variants. But when I saw that this morning, Doc, that really surprised me because I kind of always thought that maybe the kids weren't at that large of, that big a risk and that they'd be able to go back to school. But this association is saying now they got to wear masks.
I hadn't read that, so that's new to my eyes. I understand the rationale for that. Okay, so we don't have approval for vaccines in kids less than 12 and less. That probably won't come until the earlier midwinter, according to what is out there. We have this circulating variant, and here's the thing: the more circulation we have of a variant, the more likely we are to have new variants pop up. So I think that that's not unreasonable to have kids wear masks. They're going to be in crowded situations. They're going to be in classrooms for hours on end. You don't know who's vaccinated, who's not vaccinated. You don't know their home situation. So if a young child takes a virus home, he or she may not be symptomatic, but if they live in a household with someone who, let's say, is a transplant person or has cancer or has some other immune suppression, we don't want to be transmitting that back to those families. The other real goal is we want to keep kids in school, right? We don't want to have to be shutting school down and opening school up. It's horribly disruptive. So I don't disagree with that at all. That's the first time I've seen that.
Makes sense, huh? Yeah.
The other interesting thing is, so if you look at the hospital right now, and I'll use our hospital, we are packed to the gills with patients.
I heard that.
I mean, we're struggling. We're struggling for two reasons. Number one, there's a lot of patients. Number two, we're short on staff. And, the longer this goes on, the longer and the hospital is not packed with COVID patients, it's packed with many other things. But one of the really interesting things is our pediatric hospital is loaded with kids with respiratory illnesses, not COVID, respiratory syncytial virus. So one of the things that I think we've demonstrated with masking last year is when you mask, you don't transmit many of these other viruses. You don't transmit the respiratory viruses. You don't transmit the flu viruses. And so I'm not sure it's such a bad idea, particularly as we come into the fall and winter months in public places with lots of people in close contact, to be wearing masks again. I think it prevents a lot of disease.
Here's a question that I got that I thought was very interesting. And as you've always said, that's these viruses, they're variants. That's what they do. Okay. Delta variant came along and everybody's talking about that. And it's always said that it's more contagious. It's more deadly. Well, is each subsequent variant now that comes along, are they all going to be that way? Or are there variants that come out that are actually less contagious and less deadly, but we just don't hear about them as much?
It's most like, so you have to remember why viruses mutate. They mutate to survive. So every mutation is going to give a virus some survival benefit. So in the long run, they are going to be more contagious. They may be more deadly to a point, because a virus doesn't want to become so deadly that it burns itself out, right? That's what happens with Ebola. Ebola used to have such a high fatality rate that those infections, those clusters of infections kind of burn themselves out because everybody died. So the virus doesn't want to kill too many people, but it wants to be able to transmit itself and replicate. And that's what viruses do. That's what their goal is, to transmit and replicate. So I think that, as these viruses mutate, they're going to mutate because there's some survival advantage to the virus.
Oh God, Doc, just listening to you talk, it reminds me of the movie with Brad Pitt, World War Z. I mean, that's kind of the way there was a little bit of that in that movie. That's kind of scary stuff. Well, before we move off of COVID, now I want to talk about this ALZ drug, this Alzheimer's drug that everybody's talking about. But anything else on COVID that I didn't ask about here that you want to underline or reemphasize?
I just think that we have to be aware COVID is not over. COVID is with us. Please get vaccinated. As you can see, our hospitals have, 95% of people who are in the hospital are not vaccinated. And I just think that we have to make sure people are understanding what not vaccinating means. That, again, it's to protect you, but it's also to protect the population, because the more these variants circulate, the more variants we're going to have.
Well, okay. So turning the page here to talk about this Alzheimer's drug. And I'm reminded of my own personal situation. You and I have talked a little bit about this. I had a sister that died of ALS, and then I became very aware of it, obviously. And it just seemed to me like there was a lot more of it, that it was being reported more, that ALS was just an epidemic in its own right. But I talked to the ALS people, and they said they weren't exactly sure of that. There may be heightened awareness for it, but they're not really sure that there are more cases of ALS than there ever has been. Well, when you look at Alzheimer's, again, as the aging of America has occurred, as the baby boomers have gotten older, we've become much more aware of it. We're living longer, obviously, but right off the top, is there more Alzheimer's and dementia than there used to be, or is your sense it's just the fact that there's a larger, older demographic?
No, there's more Alzheimer's.
Is there?
There's more Alzheimer's. And you say we're living longer. Actually, we're not living longer. We've lost life expectancy the last 3 years.
There's more of us just because of these.
There are,
Yeah.
but we are, we're losing ground. And this year, when we look at the life expectancy statistics after COVID, it's probably going to drop fairly significantly in this country. So we are seeing more Alzheimer's. And we will continue to see more, again, the aging population, but I also think that there's environmental factors that are contributing as well.
Yeah, let's talk about that. So is this going to be solved, mitigated, let's say, reduced, Alzheimer's, that is, with a drug? And is this new drug that folks are talking about, is this a piece in the puzzle or not so much, do you think?
Alzheimer's, a lot of people believe that 2/3 of Alzheimer's could be prevented with lifestyle intervention. We know that people with diabetes have a significantly increased risk of Alzheimer's disease. There's been multiple studies out looking at levels of blood sugar and how increased levels of blood sugar, irregardless of whether you have diabetes, increases risk for Alzheimer's. So it really is a lifestyle disease. It's a lifestyle of our poor nutrition system, our poor food system, lack of physical activity, stress, lack of sleep. Okay, sleep is a significant risk factor for Alzheimer's or lack thereof. Social relationships, anxiety, all of these things contribute to this acceleration of neurodegenerative diseases. So I think that, there's many lifestyle interventions we can take. And you have to remember, before the symptoms of Alzheimer's, changes are occurring in our brain 20 years earlier. So this is not something that, you're 70, you need to change your lifestyle. It really is about changing our lifestyle and improving our health early to midlife. Now, as far as drugs, every drug that's on the market has failed at slowing the advancement of Alzheimer's. And in fact, most of the drugs have little efficacy whatsoever. So these new drugs, they're targeting these, what we call beta amyloid plaques, which occur in the part of our brain called the hippocampus. The current drug that is so controversial is called aducanumab. It's what's called a monoclonal antibody, and it targets these amyloid plaques to help get rid of those plaques. The real question becomes is lowering these amyloid plaques, does it actually translate into an improvement in clinical status? And that's the controversy here. There were multiple other drugs that reduced the level of these beta amyloid plaques. And frankly, they had no clinical benefit. What's really interesting about this drug is it's doing the same thing that others did, but those others didn't show clinical efficacy. When you look at, there's an advisory committee. So the FDA uses an advisory committee to go over the data and look at whether the FDA should approve this drug. That advisory committee was composed of 11 experts. There were experts from the Mayo Clinic. There were experts from Johns Hopkins. There were experts from Stanford. This is their life. And of those 11 people, 10 voted against approval of this drug, and 1 was uncertain and abstained.
It's interesting for me to hear you talk about this because, and you would be a perfect example as a medical practitioner. On the one hand, I mean, everybody needs to get vaccinated. They need to get this vaccine. But when it comes to these drugs, you're not near as big a fan on some of these things. And I got to say, with the vaccine, I mean, there are anti-vaxxers out there. They're Trumpies and people like that. But it's not all that. There are people that are, namaste people. They kind of want to meditate some of these maladies away. That and maybe even including COVID. But you tell them, no, don't do that. Go get a vaccine for COVID. But a lifestyle change and good living may be a better solution to the plague of Alzheimer's than drugs, at least at this stage.
Yeah, and also, and this is one of the issues with our drug development policies right now. Alzheimer's is a disease for which we have little to offer. So any little thing that potentially improves the cognitive function of patients with Alzheimer's, we get excited about. And it's the same in the cancer world. Whenever we have a disease or we don't have a cure, the FDA has allowed what's called accelerated approval. It started in 1992 with HIV. They accelerated the drug approval process. And with accelerated approval, what drug companies can do to get approval is they can show that they've made an improvement in what we call a surrogate biomarker. So in the cancer world, we want to approve drugs that improve people's life expectancy. Well, that takes years and years and years of study because we have to study it for a long period of time to actually show that it improves life expectancy. For Alzheimer's, we want to show that it improves cognitive ability of patients with Alzheimer's disease. Again, that takes years. So the FDA says, well, for accelerated approval, we'll allow you to show that it improves some biomarker of that patient. And we're going to presume that that biomarker then correlates with a positive clinical outcome. So in the cancer world, that biomarker is, tumor decreases in size. In the Alzheimer's world is, the beta amyloid plaque in your brain has decreased. Well, the problem with that is those biomarkers don't always correlate with the clinical outcomes. And by law, these drug companies, if they get accelerated approval based on conditional approval with showing that it improves the biomarker, by law, they have to continue to follow those patients and prove scientifically that they actually got better, that patients lived longer with cancer drugs or Alzheimer's patients improved their cognitive ability. And that's a huge problem because we're not following up on those well enough. So there are many drugs that were approved for as an accelerated process with improvement in biomarkers, but we've never, drug companies haven't followed up with the studies they're supposed to do. So I just think that, we've kind of relaxed endpoints in studies, and I think it's a huge problem because people are clamoring, I have cancer, I need a drug. I have Alzheimer's. And a lot of this is pushed by national associations like, the Alzheimer's Association. There's a lot of pressure on the FDA and government to get these drugs out there because we have nothing else to offer these people.
You mentioned that there are some things that you think are contributing factors to Alzheimer's when it comes to lifestyle. Are there things that in the lifestyle category now that can actually slow the progression of it once you've been diagnosed with it, or it's just going to run its course and it's going to happen?
There is data out there. Dr. Dale Bredesen out at UCLA has done a number of studies looking at intensive lifestyle intervention on Alzheimer's patients, and he has reversed cognitive decline. Not only has he slowed it, he's actually reversed it. And these are, George, these are intense interventions. These are not, eat a few more vegetables and go walk. This is intensive intervention with nutrition intervention, exercise intervention, sleep intervention, relationship intervention, all these things in a very intensive way. So yes, it can be done. And when you look at the cost of these drugs, so the newest drug, this drug that was approved, aducanumab, is an intravenous injection. It's done monthly. It costs $56,000 a year for the rest of that person's life.
God. Yeah.
So they are incredibly expensive. There was an analysis done. There's 5.8 million patients or people with Alzheimer's disease in this country. If you take that 5.8 million, let's say 1 million of these people are prescribed this drug, it would cost Medicare $57 billion for this one drug alone.
Good Lord.
That'll bankrupt Medicare.
Well, and Medicare is prevented from negotiating, I think, with these drug companies, if I recall correctly. I don't know if that's changed or not, but that was a big legislative priority, that didn't happen. And of course,
this is financially unsustainable.
Yeah.
It's financially unsustainable.
And those Alzheimer's patients may be hard hit economically already anyway, in forms of assistance and other things that they need, and you put the drug cost on top of it, and my God. Well, talking about that that scientist, that doctor out on the West Coast, Los Angeles, I think you said,
UCLA.
Yeah, UCLA. Yeah, what types of extreme interventions in those areas are you talking about? Nutrition, exercise?
Well,
How
so
extreme?
like dietary, I mean, they put patients on a very highly nutritious diet, getting rid of all sugars, all junk foods. It's really a high plant-based diet. Exercise programs, they're putting them through significant changes in their movement and things that are prescribed, things that are followed up on. But we can do this. I think we can, we can bring this to the general population. And we just have to continue to emphasize that my mantra is small changes over lifetime done consistently can result in huge differences in your life. And, the scientists, the physicists called it the butterfly effect. Small changes result in large results in the end. So my mantra for people in early and midlife is understand that the things you do now are going to affect how you live in the future. So we have to really get people to conceptualize that their lifestyle in their 30s and 40s will profoundly affect how they feel in their 60s, 70s, and 80s. And we just don't have that mentality. We have our instant gratification mentality. We don't have the long-term mentality. It's just like saving for retirement. If you don't save early in life, you're pretty unlikely to have much of a nest egg when you retire.
Well, that has to go.
Same thing with our health. If you don't take seriously your health early in life, you are going to struggle later in life.
And I can attest to that, just being from my generation here as an American. I mean, when I was a kid, it was people thought, well, you can smoke like a chimney, you can drink like a fish. And you start to get sick, or you start to worry about it when you're, in your 50s or something like that. Just quit smoking and, cut back on the drinking and you'll be all right. Well, this is a perfect example of that not being true. It's all part of a lifestyle that includes proper food and nutrition, stress management, sleep, exercise, purpose in life, social relationships, all of those things. And, the stress and the sleep are the most obvious upshots of that. I mean, if you're not doing those things, you've got a lot of stress and you probably can't sleep, and you're probably at greater risk for Alzheimer's and all manner of diseases.
Yeah, Dr. Dale Bredesen wrote a book, The End of Alzheimer's. He's convinced that with appropriate lifestyle intervention early in life, we won't have much Alzheimer's.
And other societies don't, right? That's what I've read anyway. Not as much as we do.
Well, but it's increasing worldwide because we've exported our lifestyle to the world, right? We've exported our lousy food system. We've exported our work weeks. We've exported the stress and strain of relationships. We've exported the fact that sleep is no big deal. You need to work more.
Yeah.
There's an interesting study done in Iceland. And what they did is they took a group of people and they gave them a 36-hour work week. They worked 4 9-hour days. And what they wanted to find out is, were those people happier? Were they more satisfied with their work? Were they more satisfied with their life? And of course, the biggest measure is, were they more productive? And what they found is, with a 36-hour work week, people were happier, they had more job life satisfaction, and they were 20% more productive.
I knew that they were just as productive, but it's actually 20% more productive. Yeah.
So their next study is, okay, what about a 30-hour work week? What about a 3-day or a 4-day work week that covers only 30 hours? Do people maintain that productivity? Are people even happier? Are people even more satisfied with their life? And we have got to, we have got to change the way we work in this country. We're literally working people to death. 60, 70-hour work weeks are killing people. They're killing them.
Yeah, and I got to again attest to my generation and going through the white collar world. A lot of what's happening, oddly enough, isn't actually productive work. It's actually just internal stressing. It's just misery in the workplace put upon yourself and others, and that's the lethal part of all this. You're actually not generating anything positive or creating anything. You can do that in 36 hours, like the doc says, or maybe even 30. We get to talking about this stuff, I get immersed and I forget about the time. So we're out of time, Doc. But I love to have you put a close on the podcast because I love what you have to say. Give us an ending here.
Well, I think let's tie these two things together because they can inexplicably be tied together. We've talked on the one hand about an infectious disease, which is lethal, and we've talked about another disease, which is a chronic, also lethal disease. And they both have a commonality. Healthy lifestyles can mitigate the effects of both. So get out there and pick your vegetables, eat your fruits. Go and have meaningful, thoughtful, positive social relationships. Get 8 hours of sleep, get out there and walk every day. It's you know what? It's all tied together. It's just different manifestations of our same problem. And I've talked about this before. We're a very sick country. We have one of the highest death rates in the world. Why? Because we're not healthy.
Well, that's your advice for the day, folks. That's your prescription from the good doctor, and that's going to
doesn't change, does it?
No, but it is the answer. There's no doubt in my mind, folks. That's Dr. Andrew Nish. He's on Podcast by George. If you have questions for him, like I tell people, and we put some of them on the show today. Feel free to private message me, and we'll bring these up next time we get a chance to talk to him here in a couple of weeks from now. But Doc, thanks again for coming on Podcast by George.
Thanks for having me. Bye.
Yeah, that's going to do it. That's going to wrap it up. And I always like to end by encouraging people to get all of these podcasts. Go to iTunes, subscribe there, subscribe on YouTube, ring the notification bell, give us the thumbs up there, make a comment if you'd like, and then also on our home on Facebook. But that is it. That's going to wrap it up for this particular episode. That's all there is, and there ain't no more. That's another podcast. Bye, George.